Rolled your ankle, X-ray, or fix it yourself? A rolled ankle is one of the most common injuries there is, on the court, on the stairs, on a curb you never saw. The good news, most sprains heal. The catch is that a fast drop in pain fools people. Your ankle can feel fine long before your balance, strength, and confidence come back, and that gap is exactly why so many people sprain the same ankle again and end up with an ankle that keeps giving way. The single biggest risk factor for spraining your ankle is having sprained it before. So the goal here is not just to feel better in a week, it is to recover fully so it does not keep happening. Sprains come in grades, from an overstretched ligament that is sore but stable, to a partial tear, to a full tear that leaves the joint loose. You usually cannot grade your own ankle accurately in the first day, and honestly you do not need to. The early plan is the same for most. What matters more than a grade is how it behaves over the next couple of weeks, pain settling, swelling going down, and you steadily getting back on it. If it stalls, or the ankle keeps feeling loose and unreliable, that is the signal to get it looked at properly rather than to keep pushing through. So what actually tears? Picture the foot rolling inward while it points down. That single movement loads the ligaments on the outside of your ankle. The first one to take the strain is a small band at the front called the anterior talofibular ligament, the ATFL. If the force is bigger, the injury spreads to the next ligament below it, the calcaneofibular ligament. That is why the classic sprain is tender right in front of and just below the bony bump on the outside of your ankle. Knowing this matters, because the word sprain is not the end of the story. The same inward roll can also chip bone, injure a tendon, or damage the high ankle joint above it. Which brings us to the part you actually care about: how do you know it is just a sprain? A normal sprain looks dramatic: pain on the outside, swelling that comes up fast, and bruising a day or two later. That part is expected. What you are really screening for are the red flags that mean this could be more than a sprain. Press along the bony knobs on both sides of your ankle, the base of the little toe bone, and the middle of the foot. If the tenderness is on the bone itself, not the soft ligament, that changes things. And if you cannot take even a few steps, if the ankle looks deformed, if the foot goes numb, cold or pale, or the pain keeps climbing, do not wait it out. Those are the signs to get assessed urgently, because a fracture can look exactly like a bad sprain in the first hour. A few patterns deserve special attention because they are not a simple lateral sprain. Pain that sits higher up, above the ankle joint, with tenderness between the two shin bones and pain when the leg is squeezed or twisted, can mean a high ankle sprain, which heals more slowly and is managed differently. Pain and tenderness behind the outer ankle bone, or a snapping feeling there, points to the peroneal tendons. And a joint that keeps catching, locking, or swelling weeks later can mean the cartilage took a hit. You do not have to diagnose these yourself, you just have to know that if your ankle does not follow the usual settling pattern, it is worth a closer look. Here is how a clinic answers the X-ray question without scanning everyone. It is a simple rule called the Ottawa Ankle Rules. It combines two things: is there tenderness on those specific bones, and can you take 4 steps, right now, even limping? If the bone points are clear and you can walk 4 steps, the odds of a fracture are low enough that you very likely do not need an X-ray at all. On top of that, the clinician gently tests the ligaments, an anterior drawer test pulls the foot forward to check that front ATFL, and a talar tilt test checks the one below. These are often read best a few days later, once the early swelling and guarding settle, so an unclear first exam does not mean the worst. So when is a scan actually useful? Not for a routine sprain. The whole point of those rules is to cut X-rays you do not need, while keeping a low bar to look for a fracture when the picture is off. A scan earns its place when the bone points are tender, when you genuinely cannot bear weight, when things are not improving the way a sprain should, or when the clues point to a high ankle or tendon injury instead. If none of that applies, you can skip the queue and start getting better today. Okay, it is a sprain, nothing sinister. Now the part that actually gets you better, and it is free. The core of recovery is active rehab you lead yourself, and the star is a simple heel-kicking exercise. Stand against a wall on your good leg, and lift the injured leg with the knee bent so your lower leg and thigh make about a 70 to 80 degree angle, ankle pulled fully up. Then drive that heel firmly forward and down until the angle opens to about 10 to 15 degrees, finishing with the ankle pointed. Start with 6 to 10 kicks in your first session, then do 3 to 4 kicks once a day for 4 weeks. If the joint feels stiff or catches when you walk, add an extra round or 2. If pain or swelling gets worse after a session, ease off. Keep it firm but tolerable. This is not a no pain, no gain drill. While that ligament settles, protect it and load it, do not wrap it up and sit still for weeks. In the first days, relative rest, ice, compression and elevation keep pain and swelling down. A brace or some taping gives the joint support so you can move with confidence. And here is the key idea backed by the evidence: getting moving early and bearing weight as pain allows brings back function faster than long immobilization. Motion is medicine here. The ankle rebuilds by being used, gently and progressively, not by being parked in a boot. 2 things can help you get there, as long as you treat them as boosters, not cures. Hands-on manual therapy, like mulligan mobilization, where a therapist glides the joint while you move, can give short-term gains in stiffness and balance across a few sessions. And a short course of anti-inflammatory painkillers, taken as tablets or rubbed on as a gel, can take the edge off pain and swelling in the first couple of weeks so you can actually do your exercises. Both make the real work, your active rehab, easier. Neither replaces it. What about surgery? For an acute sprain, it is off the table for almost everyone. It is held in reserve for the small minority who end up with ongoing instability, an ankle that keeps giving way, or an associated injury that has not responded to proper rehab. And even in those cases, the evidence does not show surgery beating well-run physiotherapy for most people, so it is a considered last step, not a shortcut. If you do the active work well, the odds are strong you will never need it. Now the piece almost everyone skips, and the reason ankles keep re-spraining. Before you call it healed, test function, not just comfort. Can you balance on that leg with your eyes closed, hop and land without wobbling, and trust it in a cut or a jump? Keep training balance and control, and wear a brace or tape for higher risk activity until strength, single leg control and confidence are genuinely back. That is what turns a healed sprain into a durable one, and it is the difference between one sprain and a lifetime of them. What does a realistic timeline look like? In the first week or 2 you are calming pain and swelling and walking normally. Over the following weeks you rebuild range, strength and balance with your exercises. Returning to running, cutting and jumping sport is not about a fixed date on a calendar, it is about passing function, full, pain-free movement, near equal strength side to side, and confident single-leg control and hopping. Rush back before you tick those boxes and you land straight back in the re-sprain trap. Meet them, keep the prevention work going, and you give yourself the best shot at an ankle you can actually trust again. So there is your plan, in order: rule out a fracture, protect and load early, make the home exercise and balance work your core, add support or hands-on therapy if you need a boost, and keep surgery in reserve. This video is general information, not a substitute for seeing a clinician. If your pain is severe, the ankle looks deformed, or it is not improving, get it checked. If this helped, subscribe and follow for more.